The following podcast is part of a certified educational activity titled Harnessing the Full Potential of Available Therapies for the Treatment of Lennox-Gastaut Syndrome, A Story Behind the Science. Access the entire activity and complete the post-test at www.peerview.com/XYB. Downloadable slides and practice aids are also available.
Hello, I'm Dr. Anu Patel from Nationwide Children's Hospital. I'm also the chair of the Professional Advisory Board for Lennox-Gastaut Syndrome Foundation. Today, I'll be discussing the identification, diagnosis, and treatment of Lennox-Gastaut Syndrome, LGS. LGS is a severe childhood onset electroclinical syndrome comprised of multiple seizure types, including drop attacks, distinct EEG findings, and cognitive impairment. This syndrome occurs in 2.8 per 100,000 live births and comprises between 4 and 10% of all childhood epilepsies. LGS typically manifests by age 8 years with a peak incidence between 3 and 5 years. It is also 5 times more common in boys than in girls. Despite the identification of hallmark features associated with this syndrome, LGS can be very difficult to diagnose. And that's because there's lack of specific biological markers, there are multiple etiologies, and a varied presentation of features at onset. In addition, the potential of features to evolve over time further complicates the recognition of LGS. LGS is typically a lifelong condition in which the phenotype and nature of seizures will often vary with age. Although 20 to 60% of patients have delayed cognitive development at disease onset, about 75 to 95% of patients become cognitively impaired with increasing age. Despite treatment, disabling seizures persist into adulthood in more than over 90% of patients. Only a handful of medications are approved to treat this condition. The most recent addition to our therapeutic treatment plan for LGS is Cannabidiol. Cannabidiol is a plant-based oral solution that was approved by the FDA in 2018. Now I'd like to share a story with you about a boy named Jacob. One afternoon during the summer of 2017, while they were at a family reunion at a local park when Jacob was about 4 years old, his parents noticed that on a couple occasions he suddenly dropped his head and extended his arms rapidly. At the time, his parents weren't concerned because he was with his cousins and he thought it was a game that they were all playing. However, in the next 7 to 10 days after this reunion, Jacob's parents noticed the same head drop and arm thrusting activity. These events occurred more frequently and did not appear to be associated with any of his normal activities. They were manifesting while he would watch TV or even at the table while eating breakfast. His parents were concerned enough for these episodes that they called their pediatrician, and he scheduled an office visit. 2 weeks after the family reunion and the day before he was scheduled to see his pediatrician, Jacob experienced symptoms that were consistent with what we call a tonic-clonic seizure, and that occurred while his parents were getting him out of the bathtub. This seizure lasted 2 or 3 minutes. It involved both his arms and legs, and it was associated with unresponsiveness, whole body jerking, and incontinence. Jacob was evaluated for what his parents thought was his first seizure. He was discharged home. After carefully listening to the events that had transpired over the previous 2 weeks, Jacob's pediatrician began reviewing his medical history, looking for clues that might help explain his symptomatology. Jacob was the first of a healthy child to both parents. He was born at 41 weeks of gestation. Incidentally, they noted an intracranial arachnoid cyst. However, that seemed to go away in utero and was not present by the time he was born. His birth weight was 8 pounds, 10 ounces, length of 22 inches, and a head circumference of 15 inches. APGAR scores were 8 at 1 minute and 9 at 5 minutes. In infancy, clinical examination showed no clear evidence of developmental delay, and there were no history of infantile spasms. After reviewing Jacob's history, his pediatrician began to explain to his parents that the seizure he experienced the night before may not actually been his first. She thought his head drop and arm thrusting episodes that Jacob experienced before might be seizures, but she was not sure. Nonetheless, she was concerned enough to promptly refer Jacob to a neurologist for further evaluation. A routine outpatient EEG and MRI were scheduled ahead of the neurology consultation. Jacob's pediatrician also prescribed valproic acid to treat these spells that she thought were seizures. In the time leading up to the neurology evaluation, and despite treatment with valproic acid, the frequency of Jacob's head drops and arm thrusting episodes continued to increase. They went from a few times a day to several times an hour. He also started having seizures with both his arms becoming stiff, and this lasted 30 to 60 seconds and started to occur upon awakening from sleep. In addition, a regression of skill was also noted by his parents during this time. Instead of asking for a drink, snack, or toy, he began to point at what he wanted and would get visibly frustrated when given the wrong item. Interacting with his friends became increasingly troublesome, and he became less responsive to directions. Jacob's EEG came back abnormal, and it showed what we consider to be a generalized 1.5 hertz slow spike wave discharges. In addition, paroxysmal fast activity, or PFA, was observed in Jacob during non-REM sleep. So what's Jacob's diagnosis? Could be atypical benign epilepsy, Doose syndrome, Lennox-Gastaut syndrome, Dravet syndrome, or severe myoclonic epilepsy, as we sometimes refer to it as, or even West syndrome. Well, let's study and look at the triad that's classically associated with Lennox-Gastaut syndrome. In Lennox-Gastaut syndrome, there are multiple seizure types. Tonic seizures are very common. Atonic or drop seizures are also very common. But these children can present with atypical absence seizures and even non-convulsive status epilepticus. Their EEGs are always abnormal. The common pattern associated is a slow spike and wave, so anything that is less than 3 hertz and in a generalized pattern. In addition, often patients present with paroxysmal fast activity, PFA, and that occurs during non-REM sleep, during the sleep portion of the EEG. Further, and most concerning to most parents, is the intellectual progression or regression and slowing. They often will present or start to have behavioral problems. There are key factors that predict poor prognosis in patients with LGS. Presenting with pre-existing West syndrome, earlier age of onset, symptomatic causes or abnormal neuroimaging, more frequent seizures or even status epilepticus, or those who present with focal or multifocal EEG abnormalities. Well, let's talk about the differential diagnosis of LGS as we related to earlier. We'll talk about it in relation to Doose syndrome first, which is also called myoclonic astatic epilepsy. Lennox-Gastaut, as we mentioned, the age of onset is between 1 and 8 years. It's got the classic less than 3 hertz spike and wave pattern. Tonic seizures are commonly associated with this disorder, and these occur either in sleep or awakening from sleep. The other issue is intellect is always impaired, or in almost 90% of the cases. Other seizure types are always present to make the diagnosis of LGS. The differences with Doose, or myoclonic astatic epilepsy, is that this has an earlier age of onset between the ages of 1 and 5 years. More importantly, they don't have tonic seizures. They usually have myoclonic seizures, or what we call quick jerks of the body. Their intellect can be impaired, but not normally associated with delayed impairment, and they rarely will present or have atonic seizures. Now let's compare this with another more difficult to treat epilepsy syndrome, Dravet syndrome, or severe myoclonic epilepsy of infancy. When you talk about LGS, those features are the same as we mentioned earlier. However, in Dravet, they will present less than 1 year of age, and they will often present with a febrile seizure, and often febrile status epilepticus. Their EEG will be slow, irregular, with spike wave discharges throughout in a generalized pattern, but not the characteristic less than 3 hertz spike wave that you commonly see in Lennox-Gastaut syndrome. These children do not present normally with tonic seizures or atonic. They all have intellectual impairment or regression, similarly what you see in LGS. But most importantly, these children will develop myoclonic seizures, more generalized tonic-clonic seizures, and even can have focal tonic or focal tonic-clonic seizures. Let's compare LGS with West syndrome, or what we consider a syndrome associated with infantile spasms. In West syndrome, these occur during baby time, so between the ages of 6 months and 1 year. Often the EEG pattern is HIPS arrhythmia. HIPS arrhythmia is a chaotic, unorganized EEG pattern, and these children often have tonic seizures very similarly to what we see with LGS. However, the spasms is what clearly defines these children versus those with LGS. They will have atonic seizures at times, and also their intellect can be impaired. When we talk about LGS versus an atypical benign partial epilepsy, or what some people refer to as pseudo-LGS, there are very subtle differences that you must be aware of. The major differences is these children will present between the ages of 2 and 5. Their EEG is very different than LGS. As I remind you, LGS has the generalized less than 3 Hertz spike and wave. These children with pseudo-LGS have central spikes, but also can have generalized spike wave, but not usually as slow as spike waves you would see in Lennox-Gastaut syndrome. They don't commonly have tonic seizures, but again will have atonic, which is very similar to what we see in LGS. And only about a quarter to half of these children will have intellectual impairment. They also will have myoclonic seizures and atypical absences. And very similar to Dravet, they can also present with focal onset seizures. So let's go back to Jacob. What's his diagnosis? Well, I think you could clearly see he presented with multiple seizure types. He had this interictal slow spike wave pattern. He also had the PFA that I mentioned earlier. His development was starting to regress, and he also had features that were inconsistent with the other syndromes that I just described. And more importantly, he did not present with a history of infantile spasms. So the discussion with his mother and his father went as followed. As expected, they were very, very upset. They started to cry and even try to hold back tears while the neurologist was speaking to them. The neurologist went over the EEG findings, tried to highlight how to keep a journal of his seizures and accurately count these seizures, which can be difficult for children who have multiple seizures associated with Lennox-Gastaut syndrome. She also reviewed what to do during a seizure, which is really important information to cover with anyone presenting with epileptic seizures. In addition, a number of communication points related to his prognosis were reviewed. We'll continue Jacob's stories when we come back and discuss how he was managed within the context of available treatment approaches for Lennox-Gastaut syndrome. Welcome back. Let's return to Jacob's story. After a lengthy and emotional conversation of Jacob's diagnosis with LGS, his neurologist began to highlight some general points about treatment. She then proceeded to discuss the pharmacologic treatment approaches that were available at this time. General considerations for pharmacologic treatment of LGS are as follows. You want to keep the AED regime as simple as possible. Ideally, you would like to keep children on 2 or less AEDs. You want to focus on the most disabling seizure types and treat those very aggressively. Select AEDs with a suitable adverse event profile if possible, and respond immediately to intolerable adverse events that the parents report. Be aware, though, that some AEDs can actually worsen seizures in the treatment of LGS. So let's talk about FDA-approved AEDs for Lennox-Gastaut syndrome at the time of Jacob's diagnosis. We have felbamate, topiramate, lamotrigine, rufinamide, and most recently, clobazam. When we talk about conventional AEDs for the treatment of LGS, let's talk about total seizure efficacy. If you really want to look at what people use based on survey information, valproate is the first-line medication. What's interesting, though, there's actually no level 1 or 2 evidence to support the use of this medication for Lennox-Gastaut syndrome. In fact, it is also not FDA approved, but again, more commonly used. When you compare AEDs as it relates to placebo responses, you could see that most medications that are FDA approved have a treatment response. Most importantly, we use the median seizure reduction as the benchmark for FDA approval in the United States of America. As you compare all treatments for Lennox-Gastaut syndrome that are FDA approved, clobazam has the highest chance or highest percentage of median seizure reduction as it compares to the other treatments that are FDA approved. For drop seizures, which is again a very disabling seizure type in Lennox-Gastaut syndrome, survey data tells us that valproic is often again the first-line treatment, but once again there's no level 1 or 2 evidence to support its use. In Europe, the benchmark is not median seizure reduction. They use what we call a 50% responder rate, which means how many patients in the trial had at least a 50% or more reduction of their seizures. When you look at the approved medications for Lennox-Gastaut syndrome, once again, clobazam has the highest responder rate compared to the other FDA-approved medications, which include lamotrigine, topiramate, felbamate, and rufinamide. Let me discuss the safety considerations for the available therapies for Lennox-Gastaut syndrome. With lamotrigine, there are several side effects to be aware of: tiredness, dizziness, vomiting, and rash. With rash, that can be the more severe side effect because it can progress to a Stevens-Johnson syndrome rash, and that can be seen in patients who are on concomitant valproic acid, or who go too fast on the titration schedule or start at a very high dose. For topiramate, the more common side effects are tiredness, decreased appetite, some behavioral problems, and weight loss as it relates to the decrease in appetite. When we talk about rufinamide, most commonly the side effects are tiredness, vomiting, and diarrhea. The diarrhea is usually dose related, so the higher doses can cause more vomiting and diarrhea as it relates to rufinamide. For clobazam, the most important side effect you should be aware of is tiredness. In some cases, fever can be associated with this medication. That's not accounted for other types or sources of fever. And then lethargy or being overly tired is again the one that's most commonly associated with clobazam. When we're talking about felbamate, there's some serious safety concerns that everyone should be aware of. Approximately 1 in 4,000 to 1 in 8,000 patients can have aplastic anemia. As it relates to hepatotoxicity, it's estimated that 1 in 18,500 to 1 in 25,000 patients treated with felbamate can have an association with hepatotoxicity. Let's talk about the continued discussion with Jacob's parents as it relates to his treatment. The neurologist continued discussing other treatment options and also stated that the seizures associated with LGS are very difficult to control and that it's likely going to require more than one treatment trial to find the right combination of anti-seizure medications to control his seizures. In addition, they were told about other therapeutic options that could be considered if Jacob's seizures don't become adequately controlled with medicines alone. After another lengthy and emotional conversation, a shared decision between Jacob's parents and his doctor was made to stay on the valproic acid, but also to add adjunctive clobazam. The dose of clobazam was started at 5 milligrams per kilogram per day, and it was titrated up to 15 milligrams per day. The addition of clobazam appeared to have a noticeable and meaningful reduction in the number of seizures, which were confirmed upon review of Jacob's seizure journal. This medication was very well tolerated by Jacob. This treatment effect lasted for about 12 months, at which Jacob's drop attacks began to once again start and increase in frequency. He also had 2 tonic-clonic seizures in the last 60 days, which again he had not experienced for the previous 12 months. Jacob's parents were very concerned about his increase in frequency, and his neurologist was also considered and indicated that a change in treatment was now needed. After reviewing Jacob's history, his neurologist recommended the addition of another pharmacologic treatment and add that to his current treatment plan. In addition, she felt it was important to refer him to a comprehensive epilepsy center to see an epilepsy specialist. His parents were also in agreement, and they were also interested in pharmacologic treatment approaches other than traditional anti-seizure medicines, as well as the potential of non-pharmacological options. Jacob's neurologist indicated that since at the time of diagnosis, there was a new treatment that was recently FDA approved. Cannabidiol oral solution is a plant-based purified extract shown to reduce the frequency of seizures in animal models of epilepsy. Previous open-label data from a trial of the plant-based derived pharmaceutical formulation of CBD suggests that this medication may be effective in drug-resistant cases of epilepsy, including Lennox-Gastaut syndrome. So the results of the phase 3 GWPCARE3 and GWPCARE4 trials led to the FDA approval of this CBD oral solution in 2018. Let's go over these two trials. GWPCARE3 was a randomized, double-blind, placebo-controlled trial of the CBD oral solution looking at drop attacks in patients with Lennox-Gastaut syndrome. There were 225 patients in this trial. They were between the ages of 2 and 55 years. They had to have greater than 2 or more drop seizures per week during the baseline period. They were randomized to 3 different arms: a placebo arm, a lowered treatment dose arm of 10 milligram per kilogram per day, or a 20 milligram per kilogram per day arm, and all treated for 14 weeks. Well, what were the results of this trial? Most importantly, it's shown that there was efficacy or a statistical significant decrease in seizures in both the higher treatment arm of 20 milligram per kilogram per day and also the 10 milligram per kilogram per day compared to placebo. The most common side effects in the CBD groups were tiredness, decreased appetite, and diarrhea. Interestingly, 6 patients in the 20 milligram per kilogram per day and 1 in the 10 milligram per kilogram per day had to stop the medication because of adverse events. However, no deaths were reported in this trial. GWPCARE4 was slightly different, but also a randomized double-blind placebo trial looking at drop attacks in Lennox-Gastaut syndrome. In this trial, there were 171 patients, again ages between 2 and 55, with the same baseline drop seizure frequency. However, these patients were randomized between a placebo arm and the 20 milligram per kilogram per day arm. The treatment arm went on for 14 weeks, similar to what we saw before. And the results were very similar to what we saw in GWPCARE3. What we saw specifically was in the treatment arm of 20 milligram per kilogram per day, there was a 43.9% median seizure reduction compared to 21.8% in the placebo group. That was statistically significant and showed efficacy compared to placebo. Once again, side effects were reported in a high number of patients treated in both the placebo and the treatment groups, which is very commonly seen in similar trials dealing with a very sick patient population. The side effect profile was similar as what was seen before, so you once again had diarrhea, tiredness. Those were the major side effects that you saw. 12 patients in the CBD group and 1 patient in the placebo group had to withdraw because of these adverse events. Now, 1 patient did pass away in the CBD group for this trial, but it was not considered related to the treatment of the medication. The long-term efficacy and safety of CBD oral solution is currently being assessed in a trial that's ongoing at this time. Most recently, this data was presented at the 2018 American Epilepsy Society meeting. In that poster, it showed that the efficacy is maintained and continued up into 72 weeks of treatment on this medication. Let's go back to Jacob. After discussing the available data on CBD oral solution, Jacob's epileptologist also reviewed potential non-pharmacological approaches for the management of LGS, and they include the ketogenic diet, vagus nerve stimulation, and corpus callosotomy. Let's talk about these other treatments for a moment. As it relates to ketogenic diet, there are studies that show the efficacy of the ketogenic diet in patients with Lennox-Gastaut syndrome. For those that aren't familiar, the ketogenic diet is a very high fat and protein diet with very low carbohydrates. It can control seizures for some patients and commonly has side effects that include sickness to your stomach, vomiting, and even constipation. Let's talk about some surgical approaches to the management of LGS syndrome. The 2 I want to discuss are partial or complete corpus callosotomy and vagus nerve stimulation. Corpus callosotomy is the primary palliative surgery option for children presenting with drop attack seizures associated with their LGS. It also can be effective for tonic seizures with a lower success rate for generalized tonic-clonic seizures. As this is brain surgery, there are risks that include bleeding, but also an acute disconnection syndrome, incontinence, and apraxia. Vagus nerve stimulation is associated with a lower morbidity risk than corpus callosotomy. It is not brain surgery. What it involves is a device that's implanted in a patient's chest with a wire that's tunneled up into the patient's neck. It also can be effective for children presenting with drop attack seizures, and long-term follow-up in these children did not indicate any problems as it relates to behavioral abnormalities. Side effects include hoarseness, tingling in your throat and neck, or cough that's associated when the device is activated. So after listening to Jacob's epileptologist, his parents decided they were going to try the CBD oral solution. His epileptologist felt that was worth pursuing and said they would start working on getting the necessary authorizations for insurance approval. In conclusion, Lennox-Gastaut is a very difficult to treat epilepsy syndrome. It's characterized by multiple seizure types, an EEG that has a slow spike wave pattern, and developmental regression or delays. There are FDA-approved options for treatments who have Lennox-Gastaut syndrome, and they include anti-seizure medicines such as felbamate, lamotrigine, topiramate, rufinamide, and clobazam. Most recently, a plant-based purified CBD product called Cannabidiol was approved for use in 2018. Some non-pharmacologic treatments include surgery, specifically corpus callosotomy, neurostimulation in the form of vagus nerve stimulation, and the ketogenic diet or dietary therapies. It is important to remind patients and their families about the challenges associated with the management of LGS and the likelihood it will require multiple treatment trials to find the right combination of interventions to control their seizures. Thank you for your time. I've really enjoyed speaking to you about LGS.
Thank you for listening. Download materials and complete the post-test for instant credit at www.peerview.com/XYB. This activity is supported by an educational grant from Greenwich Biosciences, Incorporated. This activity has been jointly provided by Medical Learning Institute, Incorporated and PVI, Peerview Institute for Medical Education.